The table here is actually important, and this is comparing emphysema versus chronic bronchitis in asthma, acute asthma. Emphysema is related to smoking, and part of it can be genetic, and chronic bronchitis is related to smoking and air pollution, while the acute asthma is main of hypersensitivity. There should be somewhere of some sort of hypersensitivity that start the process. And the location is very important. Emphysema is something actually happening in the alveoli, while chronic bronchitis is happening in the bronchi. The asthma is usually in the small bronchi and bronchioles. So the location is totally different. It's called like emphysema. Emphysema is the structure of the wall of the alveoli. So there is no elasticity, and it is going to when the alveoli are in the normal shape, the shape of the chest is not circular. It's not barrel shaped. That's the normal. But if the wall of the alveoli started to break down and start to be destroyed, and the elasticity is impaired, and you start to lose the elasticity, it's going to inflate. It's called hyperinflation, and it looks like a barrel shaped. And this is for the emphysema. For the chronic bronchitis, it's not even in the alveoli; it's in the bronchi. So when the bronchi are inflamed and infected, the mucus glands will increase the secretion and the signs of inflammation, including edema, narrowing of the wall in the form of obstruction, and so on. While the asthma, there's also an inflammation, but it leads to bronchoconstriction. So it's not only a matter of edema and secretions that increase to make the wall narrow. In the asthma, there is an actual constriction. The muscles actually constrict. Beside increase the mucus production, of course, that leads to obstruction. But the main thing is related to the already hypersensitive or hyperresponsive bronchioles and small bronchi. Um, in the emphysema, there will be a little bit of coughing and marked dyspnea. So the main thing is dyspnea. The patient is having hard time breathing, a problem breathing, and a little bit of coughing. While the chronic bronchitis is the opposite. It is mainly coughing, constant coughing, and some dyspnea. So it's the opposite of emphysema. The asthma, on the other hand, is cough, dyspnea, and wheezing. When we compare in regard to the sputum production, obviously emphysema is not in the bronchi, and this is where the sputum is more formed, and it's basically destruction of the alveolar wall. So the sputum is not something major; it's little. While in the chronic bronchitis, this is an inflammation, an infection that's happening on the bronchi with constant secretion of sputum that will be in large amounts, and it's purulent. And anytime we hear purulent, it's related to infection, bacterial infection. In the asthma, it's thick and tenacious mucus, so it's not necessarily large amount. It's not purulent. It's tenacious, means it gets stuck and it's thick, and so on. Cyanosis will not usually occur in the emphysema, while it occur in chronic bronchitis. It can occur, and in the asthma only if status asthmaticus, and we talked about this. Infection is chronic bronchitis is actually infection. Emphysema is not infection. Emphysema is mainly destruction of the wall of the alveoli. Acute asthma, it might be and it might not. It might be just hypersensitivity. Most of the time it is, but or sometimes it is, sometimes it's not. Core pulmonale, and we talked about this, which is heart failure related to respiratory disorder or respiratory problem. It's common in chronic bronchitis. If it is prolonged for quite some time, it's common to occur. While the emphysema, it can be late complication at the end, or after a long time. And the asthma, on the other hand, it's rare to happen, rare to occur. Restrictive lung disease. This is a disease in the lung that lead to restriction, which means the total lung capacity is reduced because of the impairment of the lung expansion. The first group is a problem in the chest wall that limits the lung expansion, while the second one is in the supportive framework. So it's not in the wall, it's in the lung itself. The first group, which is a problem with the chest wall itself, include like kyphosis, scoliosis. Kyphosis is like the vertebral column is bending forward anteriorly. Scoliosis to the side, polymyelitis. This is paralysis that lead. It's a viral infection that lead to paralysis. Amyotrophic lateral sclerosis, botulism, muscular dystrophy. These are all like from polymyelitis till the end. This is all muscle weakness. So the wall of the chest wall is becoming weak and impaired. So that's restriction of the movement of the wall. Kyphosis and scoliosis is more of physical restriction because of abnormality in the vertebral column that's restricting the movement of the chest wall. The second group, on the other hand, is actually in the lung itself, from the framework, the supporting framework of the lung. And something like fibrosis, for example, idiopathic pulmonary fibrosis, it's fibrosis, they don't know where it's coming from, it's idiopathic, and when the lung tissues are fibrosed, it will not be able to expand, and the lung capacity will decrease, so this is restriction of the lung. Occupational diseases that we will talk about, like pneumoconiosis, for example, that will lead at the end to impaired or restricted lung movement. Pneumoconiosis, this is a chronic restrictive disease. We just talked about it, and it occur if there is a long time exposure to irritant particles. There are different types of pneumoconiosis depending on the irritant and the inflammation that occur because of the exposure of these particles will gradually destroy the connective tissue. So the functional areas of the lung are lost, and this will restrict the lung movement, and hence it's one of the restrictive disease, and it's chronic restrictive disease. And the onset is usually insidious, meaning it goes slow. Dyspnea start first and then increase, and it increase. Everything goes slowly. It's nothing sudden. And treatment is, if you're exposed to dust, for example, because of your work or something like that, you should move or should work somewhere else. And if there is an infection that accompanying, you need to treat the infection. The types of pneumoconiosis include co-workers disease, or called anthracosis. The second type is called silicosis. Asbestosis is the third one, and then farmer's lung. In all of these four different types of pneumoconiosis, there is a particle that enter to the lung and lead to inflammation and lead to restriction on a long term. In the first case, which is anthracosis or coal worker disease, the coal dust is the particle or the agent, and it occurs in the coal mines. This silicosis, from the name, is from silica, which is coming from the sand. So those are the people who, or the workers who work in stone cutting, sand blasting, or mines or something. They are exposed to silica all the time, and they will get a restrictive condition that's called silicosis. Asbestosis is due to chronic exposure to asbestos. Like those are working in insulation or shipbuilders, these are all exposed for a long time to asbestosis. And again, this is a chronic and insidious process, so it takes long time to develop. You have to be working for years to get that. Farmer's lung, on the other hand, the agent will be fungal spores, and it occurs in hay, so it's like grass, around the grass. People working in the farmers or something, they will be exposed to fungal spores all the time. It will elicit the same thing of the inflammation. Now the vascular disorders, like the pulmonary edema. Edema basically is accumulation of fluid between two layers, or in a space that's not supposed to be accumulating in. or accumulation of more than normal. That's called edema. So the fluid accumulates, in this case, in the alveoli. We're not supposed to have any fluid in the alveoli or in the interstitial area. Sometimes it occurs just primary condition, so just the pulmonary edema came. They don't know exactly why, maybe inflammation or something happened. And if that's the case, the amount of oxygen diffusing into the blood will decrease, and this will interfere with the lung expansion, because instead of the oxygen going through the alveolar wall, which is really thin, and then going to the pulmonary capillaries, and then go back to the heart, instead of the oxygen crossing the alveolar wall, which is thin, now it has to cross the fluid that accumulated plus the alveolar wall, which is too hard. And normally the lung is able to expand, and if the fluid is accumulating, it will limit this expansion. And this again due to the inflammation, for example, and due to increased permeability of the capillaries. When the permeability increases, more fluid will leave the blood and go to accumulate in the alveoli. On the other hand, if the plasma proteins level is low or decreased, that will decrease the osmotic pressure on the plasma. And if you still remember how the osmosis work, the water move from the less concentrated solution to more concentrated solution, or from less osmotic to more osmotic. So in this case, if the protein is less, the osmotic pressure of the plasma will decrease, and the osmotic pressure on the other side is still the same. So the fluid will move from the capillaries to the alveoli and accumulate, and this is what we call pulmonary edema. Pulmonary hypertension, the pressure will be too much, the hydrostatic pressure will be pushing the fluids to accumulate in the alveoli. Of course, if this is a patient who's having pulmonary edema, the fluid is accumulating in the alveoli, so he will start this is irritation, so he will start to cough. There will be orthopnea, because if he sleep, the water, the fluid that's filling or not filling, that's located and accumulating in the alveoli, will give him hard time to breathe. So he has to stand up. So this is called orthopnea. We talked about this before. Rales, this is like the bubbling sound or the crackling sound that occur due to the air or oxygen, carbon dioxide moving in the fluid that accumulates. It can lead to hemoptysis, and we talked about hemoptysis before, which is coughing blood, and this has to be differentiated between hematemesis. Hematemesis is vomiting blood. So hemoptysis is here, and hemoptysis is basically the edema will contain some blood. So if he started to cough, he can get some blood in the cough. So the sputum will be frothy and blood tinged. How to treat that? Treat the cause. So if this is pulmonary hypertension, try to treat it. If this is an inflammation or infection, treat the inflammation, infection, and so on. Supportive care should be done to support the patient whatever he needs. If he needs pulmonary exercise or any type of support, sometimes he might need positive pressure like the CPAP machine or something, or mechanical ventilation in severe cases if he's not able to breathe anyway. And the lungs started to be destroyed. Sometimes he might need something like the CPAP, and the CPAP is continuous positive airway pressure. So this is air under pressure that enter the lung, and it inflate the lung and then deflate, like kind of artificial respiration. It's not artificial, but it helps the respiration. This is how the process occur of the edema that we just talked about. There are vascular disorders of something like a pulmonary embolism, and the embolus can be a blood clot or mass, something that float in the blood, and until it get into an artery that is smaller than the diameter of the clot, and then it will block it, obstruct it, whether the artery itself or one of the branches, whatever is having a diameter that is smaller than the clot itself. So the clot will be floating in the artery, moving to the periphery until it gets plugged or obstruct an artery or arteriole that is smaller than the clot. And this will depend on many factors. What the complications or what's going to happen depends on different factors, like the material. What kind of material? Size. Is it large enough to obstruct a large artery, or is it small to obstruct a small artery or arteriole? So are you affecting a large area or a small area, and so on? That will depend on the size and location as well. Which part will be obstructed, and this will give us different effects. If this is a small one, it will be silent. So it's going to go to a small area of the lung or something, and it's not giving dramatic effect. So it just they call it silent. If it is large area, that's not silent anymore. If it involved large area of the lung, so it obstructed an artery or something that supply a big part or a big part of the lung tissue. Um, if it is large, it's very large, it can cause sudden death, because all of a sudden this will the embolus will obstruct a large artery. So if a big part or huge part is affected, oxygen saturation will drop all of a sudden, and the patient can actually die. um, 90% of the pulmonary emboli start from the DVT, or the deep venous thrombosis in the legs, and it's preventable. And I think we discussed that before when we talked about the stasis in the lower limb or the legs veins that will help the blood to coagulate and make a thrombus, and this will go from the veins of the legs and go all the way until to get to the inferior vena cava, right atrium, right ventricle, and from the right ventricle it will go to the pulmonary trunk, pulmonary arteries, and it will move in the arteries and its branches until it gets stuck in one of these arterioles. Of course, after the arteries there are arterioles and capillaries, so there is no way the embolus can go through or bypass or go through the lung and leave from the other side. It will be stuck in one of the arteries. It will not even reach the arterioles to be able to go to the pulmonary veins. I mean, it will not reach the veins on the other side of the lung. So it will not go through the lung. It has to be stuck in the arteries, one of the pulmonary arteries, and the part that was supplied by this artery that's got blocked, it will be affected and it can actually die. If somebody's getting one of these pulmonary embolism, that will give a transient chest pain. All of a sudden, he get a pain because of deprivation of this part from oxygen. So he started to feel some pain. He started to cough. He have difficulty breathing, which is dyspnea. And this is if it's small emboli. So small emboli, transient chest pain, cough, dyspnea. If it's larger, the chest pain will be more, and the coughing will be more, tachypnea and then dyspnea will be more. So everything will be more than the small, of course, because it's affecting larger area. And if that to happen, later on there will be some hemoptysis or fever. So hemoptysis, again, it's coughing blood, and this is due to obstruction of a large area of the lung, and it can lead to hypoxia because of the affected part is not doing the function of supplying the body with enough oxygen. So that's hypoxia, and the patient will feel anxious and anxiety anytime if you're like in a room, in a tight room, or inside a car or something, and the doors and everything is closed. You'll start to feel anxious because of the hypoxia, and restless, and of course, and tachycardia and so on. If this is a massive emboli, not just large, it can give not only a large or a deeper pain. It can actually give severe crushing chest pain to the extent of blocking a huge area that will lead to low blood pressure, sudden hypotension. The pulse will be weak, and the patient can actually lose consciousness. How to prevent the pulmonary embolism from happening? Before the any operation, the patient has to understand what can cause the embolism. You need to move, you need to raise your feet, and so on. There are some stockings that can be used, and these can press on the veins so that the blood leave the veins and go up to the heart instead of stasis or staying in the veins to form the embolism or thrombus. Exercise is good preventive measure for thrombosis, and anticoagulants can be used as well. The diagnosis of pulmonary embolism is radiography. If you get a chest X-ray, this area will the area that's obstructed or something will look different. It's usually like a triangle or something that looks different than the rest of the lung tissue. The more advanced will be lung scan, MRI, angiography. The angiography is a dye that's injected in the blood vessels, and this will show like it's going, and it will come to a certain area and stop or become narrower or something, and that can give us an idea about which artery specifically is occluded or affected by the embolus. Treatment. You need to assess the risk factors first. Prevention will be better than treatment. If there is prolonged bed rest, then this can promote or can cause DVT or something. So they need to use compression stockings to push the blood up to the heart instead of stasis or staying in the lower limb to make the DVTs or the deep venous thrombosis. Surgery can work through putting a filter in the inferior vena cava, and this is success rate is not very good, so it's better to avoid it from the beginning rather than putting a filter in the vena cava to filter any embolus that's already formed. And you are just trying to avoid to stop it from reaching the heart, and from the heart it will go to the lung anyway. Heparin is anticoagulant, streptokinase that can resolve the blood clots. Mechanical ventilation, and in severe cases mechanical ventilation if there is a huge area that the patient cannot breathe until they take care of the problem. If they can take care of it. Embolectomy is something that they are trying. Its success rate is not high, but they can try it. So embolectomy is embolus removal. Embolectomy. Embolus, ectomy. Ectomy means cutting. So this is surgically removing the embolus. This is a picture that's showing the different types of embolism, pulmonary embolism, depending on the location and the size as that we described before. Expansion disorders is when the patient cannot expand. There is a problem that's not restrictive, but it is decreasing the size or something, and the lung cannot expand for some reason. And this include atelectasis, for example. This is the first thing. Atelectasis is collapse of the lung or non-aeration. Area of the lung either collapsed or it's not receiving air. Either a part of the lung or the whole lung. Sometimes it occur that include the whole heart, the whole lung. The whole lung all together collapse. So that the lung will not be able to expand, and hence the name expansion disorders. Of course, the blood, the gas exchange will not occur because of if it's collapsed already. So if normally it should be able to exchange air, but exchange gas. But if it collapsed, the tissues, the spaces will be lost, and the air. The gas exchange will stop, leading to hypoxia. So if there is no air in the alveoli, become airless, collapse, and it can inflame and become atrophic after time if left. Of course, the blood flow will not be able to go to this area that's collapsed already, and in this case, the ventilation and perfusion both altered. And we talked about other conditions when, like something like emphysema. Emphysema, the ventilation part is blocked, but the perfusion is okay. The ventilation is air, the perfusion is blood. So atelectasis, both of them will be affected, not only one. So what happened is obstruction. Atelectasis, one example. This is caused by obstruction of an airway. So if it's completely obstructed, if it is partially obstructed, that can cause like inflammation and difficult breathing and so. But if it's completely totally obstructed, the area that was receiving from this airway, the area of the lung, will collapse. And this is called obstructive or resorption atelectasis. Compression atelectasis is not from the alveoli itself, it is somewhere else. Something else is pressing on it, and it's called the compression atelectasis. Like a mass, any something like sarcoidosis or granuloma or TB. Granulomatous, TB granuloma, or any other granuloma, or tumor, or something that's anything mass that pressing the lung and the lung collapse, whether the whole lung or part of the lung. On the other hand, if the surface area of the surface tension of the alveoli increase, and the surfactant, as we talked about before, it's one of the factors. It's the main factors, or the main component that will decrease the surface tension to keep the alveoli opened. So if there is not enough surfactant, the surface tension will increase, and the lung can actually be prevented from expansion. So this is increased surface tension. So again, the surface tension should be decreased to keep the alveoli opened. If that's increased, the alveoli will collapse. Fibrotic change, or fibrotic tissue, I mean, if the lung, so if an area of the lung become fibrotic for some reason, the expansion will be restricted and it can collapse as well. Post-operative atelectasis, if there is a surgery that affected the lung or something, the lung sometimes can collapse after the surgery. So this is different types of collapse: obstruction collapse, non-aeration collapse, which is obstruction, atelectasis, obstruction of the bronchus, or if there is a mass or something that's pressing on the lung, it can actually collapse. So this is all atelectasis. And if somebody is having atelectasis, part of the lung is collapsed, and if this is small, it will be asymptomatic. The person will not have symptoms. It's a small spot that's not giving a real effect, so it's asymptomatic. If this is large enough, of course, the patient will have difficulty breathing, which is dyspnea. Heart and respiratory rates will increase to compensate for the part that's not functioning, and it can lead to chest pain as well. Expansion disorder, including pleural effusion, and pleural effusion is, as we talked about before, it is effusion of fluid in the pleura, meaning excessive fluid will accumulate in the pleural cavity, which is basically between the two membranes, which is the visceral pleura and the parietal pleura. We're supposed to have a minimal amount that keep the two layers kind of adherent with each other, or it's not really adherent. I mean, there should be a smooth movement or friction, no friction between the two layers. But if that's the case, it will start to accumulate enough that will give the lung the freedom to retract and collapse. So pleural effusion, and if that's the case, the pressure inside the pleural cavity will increase. The two pleural membranes will separate, and the problem is the inner one, which is the visceral pleura, is adherent to the lung. The outer one, which is the parietal, is adherent to the chest wall. The chest wall is pulling outside, and the lung is pulling inside, and they are together. So that will keep the lung inflated and in good condition. It's working. But if the two layers separate, so nothing will be pulling out. because the two layers are supposed to be together. If they separated, the one that's with the chest wall will expand, and the other one with the lung will separate, and the lung, by nature, will try to recoil, so that if that to happen, if you give it the chance, the lung will actually collapse. This can be oxidative effusion, meaning the fluid that accumulated is actually coming from inflammation. It can be transudate, and transudate means it is more of watery, not inflammation, not inflammatory fluid. So the exudation is inflammatory fluid. The transudate is more of watery effusion, and this is called hydrothorax. So hydro means water, thorax means thorax, which is in this case is a plural. So this is the presence of hydro, which is water effusion, in the pleural space. The hydrostatic pressure will start to increase, and the two layers separate, or it can come from increased hydrostatic pressure pushing the water effusion in between the two layers of the pleura, or increased osmotic pressure in the blood vessels, so that the water effusion, or the water compartment of the blood, will leave the blood, moving via osmotic pressure, again from less concentrated to more concentrated, which is osmosis, or less osmotic to higher, low osmotic to high osmotic, moving from the blood vessels to in between the two pleural membranes, which is inside the pleural cavity. In either cases, the lung, part of the lung that's affected, will start to recoil and collapse, and the patient will feel dyspnea. Of course, any one of those is dyspnea when you interfere with the normal breathing. Chest pain that come and goes, which is cyclic. The respiratory rate and heart rate, you can take it by default. Anytime you're having a problem with the lung, that will lead automatically to dyspnea because of difficulty breathing. And if you're not breathing good, you're not giving the blood enough oxygen, not giving the body enough oxygen. So as a compensation, the body will compensate by increasing the rates, the heart rate and the respiratory rate. So it goes automatically, it goes without saying. Treatment, if there is a fluid or something, you should remove the cause. And not only remove it, but you need to also analyze it, because is it just watery oxidate? Which means increased hydrostatic pressure, maybe hypertension or something, so you can treat it. Is the fluid oxidative? On the other hand, it means there is an inflammation that needs to be treated. If it is bloody, for example, it can be coming from a cancer or tumor somewhere, or TB or something. So the nature will tell you a lot about the causing or the cause of the effusion. You can do chest drainage. You can drain the fluid out. Thoracocentesis means like a needle. They introduce a needle and they withdraw the fluids in between the two layers to relieve the pressure, and most of the time it will come back if the cause was not treated. Pneumothorax, which is the next disorder. Pneumothorax, pneumo means air, thorax in this case means the pleural cavity, just as we said hydrothorax, for example. Hydro means water, thorax means the thorax, but in this case it means the pleural cavity. So hydrothorax is watery effusion in the pleural cavity. Pneumothorax is air in the pleural cavity. There are different types of pneumothorax. It will depend on what is happening besides the introduction of air into the pleural cavity. If the air entered the pleural cavity from the internal passageway, like from the bronchi or bronchioles, and there is a problem that or the alveoli, and the air starts to get an access somehow to the pleural cavity and accumulate there, but there is no opening to the outside, no opening in the chest wall. This is called the closed pneumothorax. Simple or spontaneous pneumothorax means tear on the surface of the lung, and this is why the air was introduced. This is a simple one. It just occurs spontaneously. But secondary can be caused by something else, like somebody's having emphysema, and the emphysematous part, which is becoming, it's not the regular alveoli, it's the destruction of the alveolar wall will make a large alveolus that's called a bleb, and this can actually rupture, and if it rupture, it can introduce air to the pleural cavity. Or it can be secondary to a tumor or TB, and it's eroding until it gets into the pleura, the two pleural membranes, and it will make an opening that will give an access to the air to get in between the two layers of the pleura, which is the pleural cavity. So there is open, there is closed, and there is tension pneumothorax. The closed pneumothorax is, which is the secondary or idiopathic, and again it can be caused by rupture of emphysematous bleb. The open one is actually an opening to the chest wall. Like example, somebody got a wound or got fracture of the reps that opened through the pleura to the outside, or stabbing wound or something like that. That can make an actual opening to the outside. So it's an opening in the chest wall, and if that's the case, the air will be opened between the outside of the body and the pleural cavity. It's called open. The tension pneumothorax is the most dangerous one, and the tension pneumothorax is there is an opening, and the opening somehow created a valve-like entrance to the air, so the air can enter only and it cannot leave. Open pneumothorax that we talked about, the air can go in and out, so it's more milder. But the tension, the air can only get in and it's trapped in somehow, like a flap or something, or work like a one-way valve. So the air goes from outside to the pleural cavity and it cannot leave out. So it will increase the amount of air in the pleural cavity, increase, and the lung is collapsing, and it's dangerous unless something done to stop that. Even if they have to open the flap and remove the valve, which is not the best solution, but better than tension pneumothorax. So the air entry in the closed is from inside, from the open it's from outside, and the tension, it's usually from outside from the thorax itself, or it can be tear in the lung tissue, but again it's one way. In all cases there will be some atelectasis, which is lung collapse, but the closed will be kind of limited. Because the leak will be sealed when the lung collapse, so collapse will not have an impairment effect on the lung. While the open pneumothorax, it's open, so there will be some collapse, and the unaffected lung, which will stay intact, will compress. It will push the mediastinum toward the other side. And this can the problem with that is, would start to move, that can actually affect the venous return to the heart, because it's going to be pushing to one side. On the tension pneumothorax, it's the other way around. The unaffected lung, which will become full of air, will compress the other side, so that can have effect on the lung, on the heart, which is decrease venous return. While the closed one, no effect on the cardiovascular. Signs, of course, it's the same thing. The respiration will be increased, it will be labored, it will be dyspneic, it will be compensated by tachycardia, tachypnea, and so on. Pleural pain, anytime that's introduced in the pleural cavity in between the two pleural layers, will cause pain. The sound will be absent in the closed type. In the open type, because it's closed already, so the air is not like moving in and out to make sound, so the breathing sound will be absent. The area that's contain air, you can't hear the breathing in it, and this will lead to hypoxemia. In the open one, there will be the sucking noise because the air comes in and out sucking in. So that will give you the sucking noise if it is large enough. And the blood pressure will go down and the moderate hypoxemia. The more severe one is the tension pneumothorax. Um, Breath sound will be absent in the affected side, and the trachea will be deviated, and obviously the blood return or the venous return will be affected, and it can lead to cyanosis. And in this case, there will be severe hypoxemia. Closed obviously is a mild form, open is a moderate form, tension is a severe form, with closed having some sort of hypoxemia, mild kind of. Open will be moderate hypoxemia, while the tension will be severe hypoxemia. So this is comparing the three different types. This is closed, which is from inside, and the first one, which is closed pneumothorax, it's from inside. Open is from outside. Tension is one-way valve. If this is a condition of pneumothorax, what's the emergency treatment? This need hospitalization. If this is an open thorax or a sucking wound or something, it need to be covered by something that's occlusive, like not a cotton or gauze or something. It's something occlusive to stop the air from entering, from moving in and out in general. The most important thing is to make sure that tension pneumothorax is not happening, like a piece of the cover that you're putting is making a one-way valve or something like that. So you will need to ensure that tension pneumothorax does not occur. The penetrating object, and this is something that that's important. If there is a penetrating wound or something entered, whether it's an object or a stabbing wound or something like that, it shouldn't be removed until the medical assistant is available, because if it is removed, it's blocking the entrance. If it is removed, the air will enter in, and it will even more make the condition worse. So it should be removed under medical supervision only, because when they remove it, they will close it right away by the right medical supplies that's needed in this case. So once they remove it, they will block the entry of the air. But if you removed it only, the lung can completely collapse. Tension pneumothorax, if there is something that's temporary that can be done, is change the valve, the temporary valve that's happening, or the flap that's making it a one-way valve, turn it to open pneumothorax, to removing the loose tissue that's making the valve. It's not treatment, but at least it's not tension pneumothorax. Flail chest. Flail chest is a chest that's moving in all directions, and it's usually come from rupture of the ribs, and the ribs are moving independently during inspiration. This picture here, during inspiration, it's going to move. The wall itself is going to move in, pushing the other side, while expiration it's moving out and pulling the other side. So this is flail chest, and it can push to the on the surrounding, and again it is fracture of the ribs. The limited expansion can lead to hypoxia and decrease inspiratory volume that we talked about before. RDS, which is or the IRDS, infant respiratory distress syndrome. This is a respiratory distress that usually occur in the premature birth, and we talked about this before when we talked about surfactant. And this occurred during lack of surfactant. It can be lack of surfactant due to a disease or something, or it can be actually just because he's premature, before 7 months, for example. And at 7 months, this is where the maturation of the lung start to occur. It's not 100%, but it's good enough that the infant will have enough surfactant to keep his lung breathing, and if this is not the case, in case of prematurity, the surfactant is not enough to decrease the surface tension of the alveoli, and the alveoli can actually collapse. And also the alveoli are poorly developed. It's not fully developed yet, so it's not able to inflate. So if that's the case, diffuse collapse will occur, which is atelectasis, and the blood flow, when it comes, it will be decreased as well, the pulmonary blood flow. Vasoconstriction will occur, and this will lead to severe hypoxemia, and that's why they usually put these infants in an incubator, because it can take care of the problem and they can take care of the infant. The poor lung perfusion and the lack of surfactant occur together. That can increase the alveolar capillary permeability, so the fluids start with protein start to leak in the interstitial fluid, and it can form hyaline in this case. Of course, the infant will not be able to breathe, will have difficulty breathing at birth or shortly after, a few hours or something, and he's breathing shallow and rapid because he's trying to compensate for the lung that's collapsing. Flaring of the nose is always a sign of difficulty breathing. He will be producing some frothy sputum. Expiratory grunt, he'll be grunting, making that sound during expiration. Blood pressure, of course, will fall because of that compression, and that will lead to cyanosis because of the hypoxemia. Peripheral edema will occur, severe hypoxemia, and responsiveness. Actually, it can lead to death if it's not taken care of. Breath sounds will decrease, respiration will be irregular, he can stop breathing sometimes, and so on. To diagnosis, the most important thing is gas analysis, and this will show severe hypoxemia. Treatment, glucocorticoid to the mom if she's expected to give premature labor, because glucocorticoid is a maturating agent. Besides, it's anti-inflammatory, but most importantly, it is maturating agent for the surfactant, so it accelerates the process. Even if this infant will be born like in 5 or 6 months or something, and they can prematurely maturate the surfactant and make it ready to decrease the surface tension of the infant. So glucocorticoid, synthetic surfactant, if this neonate is high risk and expected to have something like that, they can give him some surfactant that's synthetic, which is they synthesize the surfactant that have same chemical properties and functional properties. In the incubator, they use CPAP machine, which force the air in and out if the lung is not being able to breathe in and out because of the surfactant is not enough yet. So they can push the air under pressure, a little bit pressure, in and out, so the infant can breathe. If he's having hypoxemia, oxygen will be used. Nitric oxide drugs can be used to dilate the blood vessels. So this is for the infant respiratory syndrome. Adult respiratory distress syndrome is due to injury of the alveolar wall and the capillary wall. So this is another type. So the type 2 alveolar cells or the surfactant producing cells are okay. It's well developed. He's an adult. Everything is fine. But somehow injury occurred to the alveolar wall and the capillary membrane, like accident or injury or something happening, and this will lead to chemical mediators being released, and it will increase the permeability of the alveolar capillary membrane, and the fluid will leave the capillaries, proteins will leave the capillaries, and it will accumulate in the alveoli, and this will actually damage the surfactant producing cells. So this is different than the infant RDS. This is ARDS, or adult respiratory distress syndrome. The surfactant producing cells are there, it's mature, everything is fine, and then it becomes damaged or destroyed. So that will lead to necrosis and fibrosis, and actually the patient can actually die. So if the patient survives, he will have necrosis and fibrosis because of the accumulation of the fluid, huge amount of inflammation, and killing different types of cells type 1 and type 2, and type 2 is the one that produces the surfactant. And usually it's associated most of the time with multiple organ dysfunction due to the respiratory distress or due to the accident or something, and it can lead actually to failure of different organs. So the patient in this case who's having ADRS will have dyspnea. He will be restlessness because of course, hypoxia, rapid shallow respiration because he's not able to breathe normal. So he will the breathing will be shallow and fast. Tachypnea to try to catch up and get some air. Tachycardia, increased heart rate to try to transfer more blood because of the low oxygen. This can lead actually to respiratory and metabolic acidosis. And respiratory acidosis, we talked about this before, is acidosis that's caused by decreased breathing. And if you're not breathing, you're not kicking out carbon dioxide, and carbon dioxide accumulate, react with water, making carbonic acid, which is acidosis. Metabolic acidosis can occur plus the respiratory. So this is a condition that's both cases are occurring. Metabolic acidosis due to production of acids in the body due to failure of other organs. It should be treated by treatment of the underlying cause, whatever is causing this problem, and supportive respiratory therapy. So this is showing the adult respiratory distress syndrome, how it occur. And the acute respiratory failure, if that's the case, if it leads to acute respiratory failure, whether we're talking about the ARDS or infant or something, acute respiratory failure in general can come from one of the following conditions: acute or chronic conditions, something like emphysema. Prolonged emphysema can actually lead to respiratory failure. It can be acute and chronic diseases like emphysema plus something happen acutely to add up to the chronic condition that's happening that lead to failure. Acute respiratory disorders can occur. Neuromuscular disorders, for example, the neuromuscular disorders will lead to the muscles not getting get good innervation, so the muscles of respiration, the respiratory muscles, are not moving much, so this can lead to actually failure. Treatment is usually treatment of the primary problem. It has to be resolved first. See what's the problem. Is it emphysema? Is it acute bronchitis, severe? Is it severe asthma? Is it severe infection, inflammation, so on, neuromuscular disease? Whatever the problem is, the initial problem, it needs to be taken care of. And then supportive treatment to maintain the respiratory function, if needed CPAP, or if needed oxygen, if needed support, even mechanical ventilation until the condition is resolved. And that's it for this chapter of chapter 13, which is the respiratory system disorders.